So what we're going to do in this workshop, which is not actually advanced nursing, it's medication applied to nursing. Now, what I'd like to know a bit about you guys before we start. So how many of you work in a general practice? Right. How many of you are nurse practitioners? One, two. We'll jump on you. Remember these girls, because they know everything. They're right, because they can actually write the scripts and so on. How many of you work in hospitals? Yep. Okay, I thought I had more hospital. And who have I missed out? Whereabouts are you working? Home care, fantastic. And this is the way of the future. So what I've come up with the workshop today, because we did one last year as well, and I think, last year for you guys. So I'm going to do looking at problems in the old person, but not just the old person, it's the very old person today, because we're getting older and we hope that we can maintain good health. So a lot of what we do in the very old person will apply to all of us as well, and the old person. Then we'll have a break at 10:15. Then we're going to do a bit of a buzz around some of the complementary medicines and the vitamins, because about 70% of Australians are taking them. And so we'll do a little bit of thinking there. And then we'll finish off with the top 10 most frequently dispensed medications in Australia, which are statins and the PPIs and antibiotics. So just some key points on that. So we've got quite a bit to go through. If we don't get through it, it doesn't matter, because you've got the notes in front of you. I had to argue very hard to get those physical notes in front of you today, because if you're like me, you like looking at something in front of you, scribbling on it at the same time, and it was going to be really hard to get them up electronically. And I said, can't we just do that 6 to a slide, 6 to a page, so double-sided? So we've done it. So I hope you put that on your evaluations, that you appreciated it, because it's, I find without the notes, I feel lost. And I can scribble down, I'm spending all my time writing. Question? Yes, there are, thank you. And please interrupt at any time with any questions, because the time I want you to ask them is when you think of it. Otherwise, it's gone. Okay, so that's to start with. That's my late aunt who went to 95, and she had home care until about, I think it was 2 months before she went. And in New Zealand, she had home care 7 days a week, twice a day. Wow, we've got a lot to learn from it. And that is Daisy. That's Daisy by the side of her. So she was still driving to a couple of years ago. So to me, she's an image of what we'd like to be, living in her own home, having her own veggie garden, being independent. And, with a lot of comorbidities as well. She'd had cardiac problems, she had osteoporosis, she'd had crush fractures, she'd fractured 2 wrists at one stage, but she got to 95. So I think that was pretty incredible. And had all her cognitive skills. So how lucky. Okay, so what we're going to do, go through some of the medicines that we might need smaller doses of, look at polypharmacy, look at a bit of deprescribing, and let's see what we can do to prevent those falls. Because if you have a fall in your own home, then you've fractured enough, you're out of there, and you're into one of my nursing homes. I've got 35 nursing homes, 2,500 patients that we do residential medication reviews for. I also do home visits with the Home Medicine Review program. If you're not familiar with that, it's the HMR program. And I worked for divisions of general practice for many years. And when I did and we had talks for nurses, pharmacists and GPs all together. And the GPs would sit there saying, oh yes, home medicine reviews, home medicine reviews. The nurses were a bit more interested. And then I'd calculate up how many HMRs do you need in your practice to get your holiday in Santorini in Greece. And then at the end of the presentation, the GPs would come up, do you think you'd pop round to the practice and tell us a bit more about this? And do you know who drives these? You do. I do a clinic every Friday morning at Banyule Community Health Centre. My practice nurses source the patients, put them through the GPs, yep, fine, make the appointments for me, and I rock up and do 9:30, 10:30, 11:30 home visits, go back to the practice, talk to the practice nurse who implements most of the things, and then talk to the GPs, write up reports, and it's all done. And you've picked up an extra $450 for your practice, which is really helpful. You get $150 per HMR. The RMMRs, for those of you that do nursing homes, you get about 100. I get about 100 too. So we've got to think, money does speak, but it's really patient-centred care that I'm on about with it. So we'll look at the ones that contribute to the older person, and where we go. So what is old age? Is it that you're 85 and, you're old, or is it that you're 85 and you're still playing golf and you're still going on a cruise and all the rest of it? So calendar age does not equal biological age. And I'm sure many of you see people that are older than yourselves and yet they seem younger than yourselves that seem old because of all their comorbidities as well. So it is not older person, it's not the same. You've got to treat the person, not the body and not just the figures. You've got to look at how are they feeling, how are they coping, what else do they need to do as well with it. So here's another little one of my family. Unfortunately, Barry passed away last year. He was a mere 92 with it. He repartnered when he was 85, and he repartnered lovely Jo here, who is missing him terribly. They had a lovely time together. He was a millionaire, and she had no money. She was a nurse. And she was just wonderful. They just had a wonderful time. Barry looked after his wife for many years. She had dementia, so he'd said he had 5 or 6 years with her with dementia. He managed her at home until he couldn't manage any longer, and he met up with Jo 6 months after her death. And he rang me and he said, "Jenny, I'm going to live in sin, and it's only 6 months." But he said, "I said goodbye to my dear wife probably 6 years ago. And this has just been like a light. He would not have lasted as long." So you can see, need to be commended. This is fantastic. And the family have got to accept it. We have a little sometimes family disconnect with this sort of thing about inheritances, but on the other hand, he wouldn't have gone so long. The preferred term is older people, not elderly, not geriatric. They'll sort of go with seniors because we have the seniors card. They'll go, so it's older people, please. And the over 85s, that's also, they sort of start to get a bit proud about it at that stage, but between 65 and 85, it's synonymous. They don't want people to know how old they are. So yeah, just be aware, older people, not elderly. Away we go. Okay, so life expectancy's gone up. And if you get to age 65, then men another 20 years and women another 22 years. How's your super looking? This is what we've got to worry about as well. So it's the highest, amongst the highest in the world with it. So your general life expectancy, 84.6 for females, 80.4 for males. That's right across the whole cohort, not just the over 65. So it's amazing, isn't it? If you've got to 65, you can expect to go to 87. Yeah. Do you want to stay where you are? Can you manage the lawns, the garden, the trees? Yeah. Okay. So what do they all suffer from? We've got all these chronic diseases, the asthma, the COPD, the cancer, cardiovascular disease and so on. But with it, they've got all these other things that go with it that everybody has that really are often their main concern. Their constipation is probably more of concern to them than their blood pressure or their lipids. So, remember that where they're thinking, their continence is made. Their memory loss is, if they can't remember, we've got to give them clues to help them and do what we can, keep them stimulated. The confusion, not being able to get around. Falls, I can't see, I can't hear, and I'm getting really frail and my skin keeps tearing. Okay, so we also have different ways of getting the tablets into them, whether they be capsules, whether they be tablets, whether they be dispersible tablets, which we've got more of, mixtures, so on. Some of them have all their when I go do the home visits, and we've done about 10,000 of those, and you're going into people's homes as an education. Sometimes I think if my family could see some of the homes that I go into, or a few of them, I can't even get in the door because of hoarding, and or the smells, and you're actually out on the balcony. How many of you do over 75 home checks? You know what I'm talking about, don't you? Yeah, it's absolutely mind-boggling. But one of the biggest problems is adherence. Are they taking their tablets? Are they doubling up? Or what is going on? Not everybody suits having a dose administration aid made up by the pharmacy, the Webster. Because when I see them, you might think they're confused, but if you sort them out and they are in control, I leave them doing that. Because if you shift them to a Webster pack, the next time I see them, I say, "What are you taking?" "Oh, I don't know, I just punch them out. I used to know all my tablets, and I don't." So I think each person is an individual how you assess them. I'm very happy that they put them in, the gentlemen, in their old rusty fishing tackle boxes. I'm very happy that they put them in other little $2 boxes from the $2 shop, as long as they're correct. The lady I saw last Friday, she had 2 of them, one for morning and one for night, but they all had different quantities in, and she had all over the place. She had 1 slow K in the morning and 1 at night, and some of them, others she had 1 in the morning and 1 at night. She had the metoprolol, she couldn't manage to cut it in half as she was supposed to, so she just put the full one in at night, and then sometimes she'd forgotten that one as well. So she was actually in the case of needing to have a dose administration aid, a Webster type pack. And when I suggested, she said, "Oh, yes, that would actually be so much easier." You know, she was, at the start of the interview, she was feigning her independence, how capable she was, but when she sort of saw that it wasn't quite right, she then said, "Yes, it would make it easier for me." So I think it's just talking to them. What I do have is the luxury of time when I do the home visits. You know, I have an hour at least. If I've got a tricky one, it'll be more. It's very seldom less than that, even if I've seen them the year before. Officially, we can only do the HMRs every 2 years, but you get paid under the MBS every year. So if you put it in a day after the year, you don't get queried. If you want to do them after 3 months, you need to write a little story about there was an urgent medical need, they'd had a hospitalisation, significant change, and then you should get paid under the MBS for it. Officially, the Guild, Pharmacy Guild say 2 years for us, but often it's not appropriate. Sometimes it is. In the nursing home situation, it's certainly not appropriate. We need to go more frequently. One of the important things is, can they swallow? And if they can't swallow, they are crushing their tablets. So you might just mention, you know, when you see them, you know, you've got quite a lot of scripts here, can you swallow, you're managing okay? Because some of the pharmacists forget. And if you crush something like Isoptin, 240 milligram slow release, guess what? Instead of getting a nice even distribution over 24 hours, you get the whole lot all at once, and you get a bradycardia, and the heart goes, "I think I will stop," and it does. And I've had a death from that, and I've had about 3 hospitalisations with that particular drug. So anything that's got MR, SR, CD means it is sustained release, and it must not be crushed. We have a book that thick, which I didn't bring down, but I'm one of the authors of it, and that's the Society of Hospital Pharmacists. Don't rush to crush. It's available on MIMS, it's available on OSTI for an extra sub, but every pharmacy in Australia is supposed to have it. I say supposed to have it, because some of them are too stingy to pay the $200 and something. It's a lot of work in it, but it gives you everything of what to do with options, and it also talks a lot about nasogastric tube feeding, which we're going to see a lot more coming into the community in our old people with it. So I think we've covered most of. Oral lubricant. I knew you guys would catch that one. Yep, okay. It's Gloop, and it's for helping swallow tablets. Have anyone used Gloop? I'm not usually promoting tablets, but it's very useful because it's inert. The only thing is it costs. If you contact the company and ask for some samples, they'll send some out for you so you can try it. The original flavour was cherry. The later flavours are, and the cherry they didn't like because it's got sugar-free. But the orange has got sugar in it, so has the vanilla, and I think there's another flavour too. So that's quite handy if all else fails and you can't crush or disperse them, or you can't change. Often I'm looking at changing the tablets, and that's where medication review comes in handy, because we can make suggestions. She's starting to have trouble swallowing. Can we deprescribe, get rid of some medicines? Can we shift those Targan off to a Norspan patch? What can we do to make it easier for them so that they can manage their medications? Any questions so far? Okay, no? All okay with all that? Yep. G-L-O-U-P. You can just Google. Yeah, you can just Google it. I mean, the problem, you can swallow them down with yogurt, or you can use ice cream as long as it doesn't interact with calcium. So you've got a few things such as, for example, doxycycline. If you took that at the same time, it would complex. So you're just safer. But half the time they won't always pay for it. $15 for a small tube and about $35 for a pump pack. So that's quite a bit of money for them. Even having a couple of good sips of water prior to swallowing their tablets helps, because a lot of these older people have got dry mouths and they just can't swallow. Try and get them to take calcium, Caltrate. Any of you take Caltrate? How hard is that? I'll tell you what, they can get all the multivitamins down and they're massive. They're really horse pills. But the Caltrate, what we can do with that one is that there are chewable forms, Calsup and so on. But ideally with calcium, which I'll do in the next talk, it's better to get it from your diet, as much from your diet as possible. You'll find I'm a very odd pharmacist because I don't actually encourage a lot of medications if we can do other things with it, sensible things. Okay. So what makes a difference? Here's one of my ladies in a little aged care home, and she's out there, she's been sweeping, and that's her little garden here. So, some of them have got, even though she's in a low care home, they closed that one down because it wasn't making enough money. They had too good a staff ratio, I think. So it was absolutely beautiful. So we've got, depending on their prognosis, depending if they're at home, if they're living it alone, one of the important things outside medication is an alarm. If they fall over, can somebody know? It makes me think of one of my ex-neighbours, Eileen, who used to look after my children one day a week so I could maintain working. And in the later time, we'd shifted from there, but she had a fall out in her concrete backyard where the clothesline was, and she fractured both her wrists at 9 in the morning. Now, she was quite a big lady. She could not get up. And she lay there until Maria, who was my next door neighbour, who happened to be a nurse, got home at about 4 o'clock and heard this weak voice saying, "Help, help." And there was Eileen with 2 fractured wrists. She'd had sunstroke because it was quite a warm day, and she was covered in ant bites all over her. So whenever I say to people about getting an alarm, I tell them that story and they go, "Oh, I wouldn't like that to happen." Well, how much does it cost? Well, depending on your personal circumstances, it may be able to be arranged nothing. My mother's case, who'd had a couple of one heart attack and was going to live on her own, I said, "You're not staying here, Mum, unless you have an alarm." In New Zealand, that one cost $1,000 because she wasn't eligible. So what's if it does cost $1,000 for a year? How much does it cost to get into one of my lovely nursing homes that I'd like to be in? 600,000, $1 million if I want a bit more space? So 1,000 is a very small price to pay for your security, and also it keeps the family off their back because the family want to shift them into the nursing home and Mum wants to stay in her own home. So it's, you people are the main key holders of the getting alarms and talking to them about it, and also setting up all the services. So what sort of services does she have? Does she have 1 hour every 2 weeks for somebody to come in and help her? Or can we do more? We mightn't be able to get more on the council. How about we start to talk to people around the street and say, would her friends, would they be able to come in and she can pay them $20-30 for taking her down shopping? I think it's using the neighbourhood support of people. The family aren't always available, and they don't think about, somebody at your local church. Is there somebody at that Probus club that you go to that would be happy to come in and give you a hand? And certainly, in my mum's case, she had a council person, but she had another lady coming on Monday. I said, "Oh, why do you need her?" "Oh," she said, "she's just so nice, and I just love her." And she said, "I've invited her around for morning tea while you're here." This is in New Zealand. I said, "What? The cleaning lady?" She said, "Jen, she's not the cleaning lady. She's my friend, and she's my helper." Oh, and how insensitive of me. And she became a really good friend of the family. And that's what it's about. It's helping everybody and thinking, if the system doesn't allow us to do it, let's go outside the system and pay that little bit of money privately. And you guys can do an awful lot in this personal care, in this personal space. We can also get RDNS or MECRA or Bolton Clark, as they are, to come in and give the tablets every day or twice a day in some cases. You've got to pay. But that can be set up, and it works extremely well in a lot of the people I see. So we've got retirement villages, which are very supported as well. We've got supported accommodation in Victoria, which is doing a service, but I do the training of it, and I get worried about the quality of care because often they haven't got a nurse there, and it's owned by somebody who's trying to make money out of people who can't manage themselves. So I think we're going to see an inquiry into that before long. The low care facilities have now merged with the high care. As soon as you go into a nursing home, you're classified as high care because you're going to have sorbitol cream put on every day so that you've got the next category under the ACFI classification. So they get paid more money. So, but it is certainly still graduated care. So we've got lots of things, but what I want to focus on particularly today are these people living alone at home and in their retirement villages, which would be your main population that you're seeing. Yeah, okay. Driving. One of the hardest things to do is to tell somebody they can no longer drive, okay? So GPs hate doing it. Years ago I did a big campaign throughout Victoria when I was doing a PhD on driving, and put full-page ads in the Sun Herald and The Age and in the seniors. These medicines can have the same effect as 0.05 on your driving. And it was very, very successful, except some people stopped taking their medicines because they thought that they were going to be taken up by the road protester. But certainly we do need, and you've all seen the cases when they back out of your car parks and you go, oh my gosh, she's still driving? Oh my dear. And we've seen multiple photos of people getting their medicines from the pharmacy and then going home, but putting their car into forward gear instead of reverse and going through the front of the pharmacy. And I've got a whole collection of those ones, so that's really bad as well. And if we've got an OT, they can assess and it takes it out of your clinic. And so if you can find one, and wherever you are, there's certainly one where I am at La Trobe University, and the GPs love to be able to refer. Well, it wasn't me, it was them who took away your licence. Otherwise, it's the family, and then this family disconnect again. And the man will say, well, I used to like going to that doctor, but I think he's lost it. I'm going to change surgeries. Yeah, and so you've lost another patient if you've told them that you can't drive. So it's a matter of providing the half-price taxis, the option there, talking to them about it. If they're going to the hospital, how are you getting on with parking? Is it a stress for you? Oh, I can't sleep for about 3 days before I go there. I'm so worried about that I mightn't get a park and it costs so much, and etc. So we've got to start to get them to say, look, I think I'll give up driving, whatever. What about my dad? He went to 91 and he was not allowed to drive. They'd taken his licence. Mum goes out to see if where's Harold gone? The car? Oh my gosh, the car's gone. Yeah, he'd got in the car, gone down the road to get his bottle of whiskey because he knew that she wouldn't buy it for him, and came back and she said, where have you been? He said, wow. She said, you can't drive. He said, well, what do you mean I can't drive? I've been driving since I was 15. Of course I can drive. A little bit of cognitive impairment there. So the car keys had to be actually hidden, so he couldn't get in the car again. But they're very, very determined about, particularly the males, of wanting to continue driving. So good luck with what you can do with this one. Okay. We put labels on the medications, label 1 that may affect driving, sleeping tablets, all those opioids, they're bad. So we come to polypharmacy, and polypharmacy is just basically a lot of medicines. But there's good polypharmacy and there's not good polypharmacy. If you've got multiple comorbidities, say diabetes and cardiovascular disease and osteoporosis, you're going to be on 6-7 medicines for your diabetes control. If you're looking at good blood pressure control, you might be on an ACE or an ARB, you might be on a second agent as well, you might be on a lipid-lowering agent, you may not be on aspirin these days, that's very debatable. That's 4 to start, and then you've got your metformin and your sulfonylurea and maybe a gliptin or something. So you've got 7 before you've started to treat for your osteoporosis and your osteoarthritis and so on. So you're really getting up to polypharmacy. So it can be rational, but it can also be not sensible, and we'll show you some cases as we go through. So my favourite word is deprescribing, and deprescribing should be done at every stage of life, not just at end of life. And nurse practitioners are particularly good at deprescribing. You go where angels would fear to tread, and you go, yes, I don't think we need this, and we can see how we go and we can stop it. And I do talks on just deprescribing. If you want to know more about it, I'm actually a writer of the RACGP Aged Care Handbook, the old silver book. It's still available as a silver book online on the RACGP. There's a new edition coming out, which the first stage will be coming out in August, and I've written that chapter on deprescribing. There's a particularly good website, which Consultant Pharmacy Services, you can in Tasmania. You can just go on to Deprescribing Tasmania and it'll bring it up. And that's got all the guide to deprescribing. It's got about 15 different classes of drugs. You can do the concise, quick version, which the GPs like, or you can go to the more detailed version, which has got 3 or 4 pages about each drug, about all the ins and outs of proton pump inhibitors and deprescribing. So that's a very useful guide. There's also one coming out of Sydney University. There's lots and lots of guides coming out on deprescribing now. Not all medicines can be suddenly stopped. So what we try and do is ceasing medicines that have got unacceptable adverse drug reactions, ceasing the medicines that are no longer being used, ceasing the medicine for a condition that is resolved. The other thing that we're looking at is new name for something, and it's called not deprescribing, but unprescribing. I'm going to call it deprescribing, because often when we look through the medical history, you've got current conditions and you've got inactive conditions. And when we're matching up the medications, you may find that there's still some medications that are being treated for the inactive conditions, which could really come off, and then we could have a far more accurate diagnosis for it, that it's no longer sensible for that person. So we try to cease the higher risk medications, and I'm doing a talk tomorrow on risk management for those higher risk medications, and ceasing them, as I said, prior to end stage. For yourself, have a look at your own medicines. Do I really need to take all these medicines? Are there any that perhaps I was taking that I no longer need to take? Could I try and get the doses down of, for example, the proton pump and so on? So unfortunately, some people don't want to stop medicines, but one of the things I find when I go for my interviews, I say, is there anything that's worrying you about your medicines? Oh yes, I'm taking too many. You know, are there any that I don't need? And so that's something that I put in my reports back for the prescriber to consider. Do we still need this or not? Mavis indicated that she would really like to try and get off her sleeping tablets. Well, that's very positive for you guys and your GPs to know that she's thinking about weaning off her sleeping tablets, because then you've sort of started that through that pre-contemplation stage and you're moving on, and we can start to develop a plan. Weaning off Diazepam is not an easy task, because if you've been taking Diazepam every night for 3 weeks, you are dependent on it. You are addicted to it, okay? So, and taking 2 or 3 times a week, you can probably get by. But after 3 weeks, if you just stop it suddenly, they won't be able to sleep. They'll have benzodiazepine withdrawal. So you need to go down very slowly, and there's weaning programs for it. If they were taking 2, you'd go 2 one night, 1 3/4, 2, 1 3/4. Then you go down to 1 3/4, 1 3/4. Then you go down to 1 3/4, 1 1/2. So it's very gradual. And if their medicine's packed in a Webster, the pharmacists hate you, because it's a real fiddle. But it's the only way to go. If you go cold turkey, they'll really have sweats and anxiety and so on with it. So it has to go down gradually. Melatonin's an interesting one, and melatonin is only indicated for up to 13 weeks in an older person. And yet I've got stacks of people in nursing home having it these days. We don't know the long-term effects at this stage, and it doesn't seem to be problems when we take them off it. But it's intended only for short term to reset the body clock. Okay, it's not pharmaceutical benefits, so they really don't want to pay, but yet they are paying. So that's an interesting one to ponder and discuss as well. I certainly take melatonin myself if I've been to Europe and coming back to stop the jet lag, but I find about 4 or 5 days, fine, and I'm back to normal. Otherwise, I'm still awake at 3 or 4, and then I can't get up to go to work in the morning. You know, I'm absolutely groggy. So it is very helpful that way. Coming the other way from the States, no problem, but coming from Europe, I find it's useful. But that's an aside. Okay, so when do we see, deprescribing, when do we cease the statins? When do we cease the osteoporosis? What about the cholinesterase inhibitors? So I say the reluctance of the older person, sometimes it's the family, particularly. If you're considering stopping the Aricept, you always have a family conference with them, particularly in the nursing home situation. Otherwise, they will change the doctors, they change the surgery, because that is the last glimmer of hope with it. The same with the statins. It's very difficult. Again, it needs to be done with the family as well, because a lot of my discussions with my GPs are that, well, look, if I know what you're saying, Jen, but if I stop it and she strokes out or she has a cardiac event in the next few weeks, they're going to sue me. So they get very worried about this. So it used to be much easier when we were doing liver function tests routinely, because you could see deranged liver function tests. You say, well, look, the body can't cope with it. So that's almost worthwhile doing it as another sort of armour that you can say, well, look, the liver's not coping as well with it. But we've also got to think about what are we trying to achieve with our targets. What are we trying to do? 80 milligrams simvastatin, if they've got side effects, they've got their aches, well then, we've got a good case for it. But we've got a lot of unnecessary use in a lot of these older people as well. The osteoporosis, we've got to think of when do we start it and when do we stop it. If you're starting now on denosumab, Prolia, then if you stop it, your bone mineral density is going to go back to where you were before you actually started with the Prolia. So it's basically ongoing treatment. When it first came onto the pharmaceutical benefits, it was only on for 3 years. Now it's on continuous. So if you've got somebody who can't tolerate it, you've got to think very seriously whether they need a bisphosphonate, if you're going to take them off it. Otherwise, their risk is going to be increased. So the other thing is, when do you put them on it? I mean, as early as possible is really the secret of it. So it's not much point starting mum at 94, 95 if she's in a nursing home, but it might be if she's living in her own home and she's still independent. So as I say, each case has got to be assessed. There's no gold rules for this one. We'll have a look at a few cases today, just to bring it back into relevance. So here's Valda. She's 85, but she's living in an aged care home. She's got a reasonable weight, probably a bit overweight with it, which is not a bad thing. I think frailty is another high risk factor for them. She's had post-traumatic stress, a whole lot of conditions there. She's had a few adverse reactions, her pathologies there. Her GGT's up high. You immediately think, oh, is she on the sherry bottle? What's happening there? But she's in an aged care home. So something's going on and her renal function's going down. So she's on a stack of medicines here, and amyloid, which we very seldom use, which can actually retain potassium. You immediately see perindopril, which also maintains potassium. She's on Stemetal. Stemetal is one of the ones I really want ceased, because Stemetal is for symptom only, and that's why you only get 25 on the pharmaceutical benefits. Because would you like to be on long-term Stemetal? Tardive dyskinesia being one of the main adverse effects of it. So we've got to say, why is she dizzy all the time? What's going on? Is her blood pressure too low? She's had no regular blood pressures. The last one was 144 on 88. What's going on? Torvastatin, she's got esomeprazole, she's got some diazepam. That's going to increase her risk of falls. She's got some quetiapine. What did she have? Did she have she had PTSD. Does she still really need that? Quetiapine is now a street drug as well, so it's being abused as well. Venlafaxine as well. Mirtazapine. So she's got 2 antidepressants. It is actually really instructive to actually look at what these people are actually taking, because your lists and your surgery, often there's things on that list. When I do my reviews and I get the referrals from you guys, what you have on your list, what the pharmacy have on their dispensing list, and what the person are taking is 3 different things. So what I can feed back to you is what they are actually taking, and then you guys can update the list, because your GPs don't. I worked for divisions of general practice for 7 or 8 years, as I say, and I know what the practice nurses did. They did all this sort of stuff because, oh yeah, I'll get round to it. And then 2 years later, I see that the amoxicillin that they had 3 years ago is still sitting on the current medications. So, this is a very important role to get the accurate drug history. No point sending up to my health record if you've got incorrect data. Garbage in, garbage out. Okay, so here we go. We've got 2 antidepressants. Why? Well, sometimes we have that, and if they've come from a psychiatrist, you might say very well, but there's an interesting case where high doses of mirtazapine actually cause insomnia. Doses up to 15 milligrams will make them sleepy, so, could that be causing her insomnia as well? And she's on that diazepam, and her depression's not responding. About 30% of people don't respond to a particular antidepressant. So, there's something going on there. She's got some paracetamol, and you might say, well, 1-3 times a day, but that might be enough for her with her low renal function and her liver function test. She's got some vitamin D. She's got some more Stemetal on top of the regular ones, and she's got a bit of Fairs. So, yeah, we can see that she's got problems. Now, in this particular lady, we did a pharmacogenomics profile, which is your personalised medicine, trying to identify why she hadn't responded to some, and we look at these liver enzymes, and I think we'll all be having these eventually in the future, and you'll be able to predict things. But a lot of the time, because there's so many different mechanisms in the liver of metabolism, it's not that clear as to, they could be deficient in 2D6. If they got a very low CYP2D6, they're likely to be sensitive to codeine, because they can't metabolize the codeine to tramadol, so to morphine, so they'll be actually unable to tolerate tramadol, and they'll probably be unable to tolerate paroxetine, because that's its main metabolism route. So this is where we're starting to move with this personalised medicine as well. If we look at Valda, again, her daughter recently moved away. She got more worried by it. her cognition is down, her behaviour, she's obsessed. They've tried to change the venlafaxine. So this is the complication of this older person. It's not just straightforward. So in summary with this one, we'd have a look at whether she needs the amyloid, whether she needs Rindapol. Maybe by taking those off, she mightn't need the Stemitol. You see where I'm going with that sort of thing there? The lipid lowering, is it still needed? Does she really need that low-dose paracetamol? Is it making a difference or not? What's her pain assessment like? Has that been done recently? If we look at the use of diazepam in older people, it hangs around a long time. And it's even worse if they're driving. Their reactions are much slower to react when they're coming towards you. Okay? So just be aware, it slows the reaction. They do develop tolerance to it. There's no point in doing blood tests for it because everyone is variable with that one. It's a very interesting situation. She's got multiple antidepressants. That's not a good idea with it. And additional use of the antipsychotic. We didn't have a diagnosis. So that's a bit about your pharmacogenomics profile. If you wish to read more about that, there's a company called Genes FX that you can ring up anytime. I can actually, as a pharmacist, prescribe the gene testing for it, but it costs about $200. But it's early days with this, but it's certainly starting to move more into the personalised medication. So in summary, some of the things that we find that are inappropriate in older people, which were developed by the Bears Index, tricyclics, the old antidepressants, the amitriptyline, the Diazepam, the Doxepin, those ones make you dry mouth, constipation, difficulty in maturation, cardiovascular concerns, and falling over. So when you're old, do you want to be on them? No. Yep. Okay. Interestingly, the NPS are detailing out at present on neuropathic pain. Number one for neuropathic pain is amitriptyline 10 milligrams. So we're having a big argument about that on our ROCGP committee, whereas it's okay for the average person, but for our old person, it may not be first line. So we've got to think very carefully about those adverse effects with it. And it certainly isn't a good idea as a sleeping tablet, which is still used in some cases. The sedating antihistamines, by that I mean the polaramine, I mean the Phenergan, and I probably mean the rest of it, which a lot of night staff nurses use until they found on the recent study that it impairs memory, and that actually stopped a lot of the sale of that. Anyone still taking it? Yes. Okay, take it very seldom. Benzhexyl, benztropine, they've just about gone with the anticholinergic type effects of it. Chlorpromazine, Largactil, very seldom see. Cimetidine we hardly see. Ranitidine, it can cause a confusion. The good thing about it is it is reversible. So that's one thing about that. Diazepam, together with all the other nitrazepam, we probably put oxazepam there as well. The Doxepin and the Diazepam are the tricyclics. Rohypnol, they S8 now, very, very seldom see them. Glibenclamide, your old Dianol, hangs around too long in the body for the older person, more likely to have hypoglycemia. Hydrochlorothiazide, 50 milligram, I'd probably go 25 even, and you occasionally will get metabolic effects at 12.5, but it's going to cause hyperuricemia, increased incidence of uric acid, more chance of having gout with it. So we've got to watch out for that one. All the non-steroidals in older people are not a good idea. We'll go into more detail with that one. Particularly Indicid. Methyl-dopa gives them depression. Maxilon, metoclopramide, long-term is not a good idea because of the extrapyramidal side effects. Nitrazepam hangs around in the body for a couple of days. Oxybutynin, Diazepam, is my least favourite drug because it is an anticholinergic agent. In my nursing homes, I see people on Diazepam, and I look at their history, and the nursing staff have classified them as incontinent. They are regularly in pads, so why are they on the oxybutynin that has all the anticholinergic effects? It dries them up, it makes them confused, it makes them increase falls, and we take them off it and they improve. On top of that, if they're on oxybutynin together with their Aricept or any of their agents for their Alzheimer's, you're going to get, it counteracts the effect. So they've got no chance of getting any benefit from their galantamine, their Remerol or their Aricept if they're on oxybutynin. So look for that one. You might find it. No? In fact, you will find it. Piroxicam, Prazosin, mini-press. Anyone know anything about mini-press? Beware the first dose effect. It is a peripheral vasodilator. had a death from that one. How did it happen? A nurse giving the wrong medication to a resident. Very easy. There's in a very nice nursing home, one of my favourite ones. This nurse had actually got the medicines, checked them against the chart, all was there. They all were crushed. She crushed them. Beautiful. Oh, you okay, Mary? Oh, you just fallen out of your chair. Oh dear, poor Mary. Yeah, okay. Now where was I? Yes. Now I'd given them to you. Now here you are, dear. Here's yours. Let's give it there. Come back. Oh my God! I was supposed to give them to you. I gave them to her. And this little lady here was, with respect, 47 kilos. And this lady here, with respect, was 150 kilos. She's saying, where's my medicine? Where's my medicine? So this one got 3 blood pressure tablets, including mini-press 5 milligrams. Blood pressure, drop, drop, drop on the bed. Ambulance there within 10 minutes. She died 45 minutes later in the Austin hospital. That nurse didn't work for 12 months after. So whenever I see mini-press, I go, oh! You know, you start on 0.5 milligram. This lady, you know, who was supposed to have it, had been stabilised on it, so it had gone up. So any of you who ever have to give out medicines or anything to do with mini-press, just go, ooh, watch that one. You start slow and you go up very slowly. Fortunately, the family didn't sue because it was handled very well by the nursing staff and it was put down in the courts as human error. I actually had to counsel all the staff of that particular nursing home. We're all devastated, still devastated, 2 years later. You know, these things happen. And you've got the best processes in, but human error. It's all your fault, Mary. Yes! Yeah. Okay, that was what prazosin. Whenever I see prazosin, you see it brings it up. Stematol, propantholin, probansin, and there's a lot more. So those are the inappropriate ones, and we've got all sorts of medicines at inappropriate indices. So we've got falls-related injuries in Australia, and as I said, falls are slips, trips on the same level. I work with 2 falls management groups. We have groups at the Banyule Community Health Centre and Darebin Community Health Centre, set up by the physios. They are brilliant. I'd love to see more set up in some of your GP practices where you bring in the GPs. The problem is costing. Because this is community health in Victoria, we've got state funding. So we have 6, 7, 8 people coming in for 6 weeks. They come in for 2 hours on a Wednesday afternoon. They have 1 hour of group physio, usually with 3 physios, doing the exercises. They then have some cheese and biscuits for afternoon break, and then I come in and give a talk on the medications of the ones that can actually cause falls. 1 week, the other week they might have a dietitian, they might have an OT, they might have a podiatrist, they might have a counsellor. Absolutely brilliant. And we get really good outcomes from that. And then they follow up with their other 5 visits. And do you know how much it costs them? A gold coin donation. I mean, this is where it's all about funding, but it's something that some of you with innovation could set up. We've also set up exactly the same protocol for the pain management groups, and we're doing those every 6 weeks. And you know what? The people I've got there are not on the opioids. They were about to go on the opioids, but we've got them, because what are the main things for osteoarthritis now and low back pain? Weight reduction, exercise, physio, physio, physio. It is not the medications from the pharmacist, okay, or the prescriptions from the GP. It is self-management. And if you're not going to get them all, but at least if you can get some before they get on the medication trap. Okay, so there's lots of causes for falls, which you know, with relating to balance and so on. So walking is really important, to be able to walk right and to make sure that their gait is right, and it might be referral to the podiatrist to make sure that their toes are not hurting, that they've got the right pronation and so on. So very important. Okay, some of the medications that cause falls, again, what you would expect, those that have label 1 from the pharmacy, the antihistamines, the sedatives, the hypnotics, the opioids, the antidepressants, you name it. There's an awful lot that can cause falls. The NSAIDs also can as well. So I've given you a chart there, which I'm not going to go through, but it's for your reference if you're interested. And you can see that, you know, alcohol causes you confusion and difficulty in walking. The benzos cause you difficulty in walking. Reduced proprioception, that you're not quite sure where you are in space. You know how you have too many drinks, it's a bit spongy? No, you don't know that, do you? I don't know it these days either. Never had more than 1 or 2, but I can remember years ago. And you felt a bit fuzzy? Yeah. Yeah, never, Mary. No, okay. So, diuretics, furosemide, that's one of the biggest causes of falls. Because why? They're rushing to get to the loo the half hour after, so they need to be, maybe they've got to wear a pad or they've got to have something there to help them with it. Levodopa, the most common one to cause a postural drop, and so we go on. So we talk about the anticholinergic burden. If you're not getting the MATES publications, get them. They are fantastic. You've got ones that are for patients, and they're put out by DVA in South Australia. And then you've got the ones that are for the health practitioners. And they have the best guides. They've got a very good one on anticholinergic burden. This month they've got one on deprescribing and polypharmacy. So please, if you don't get them, just Google veterans mates and get your surgery on the list for it, and make sure that you read it, that you put the copy out for your patients to read it as well, and your doctors also read it. They are just so well put together. I'm very commending about those. So it talks about all the ones with the anticholinergic effects there that can cause this confusion and making the people not operate as well. So you've got your antipsychotics, your antidepressants, your bladder agents there, your antihistamines, your tapentadol, your opioids, all your opioids as well. Some of the inhaled medicines are going to add to it, and there's a whole lot of others. And what we have is a anticholinergic burden, where we might add, you look at the list, and then we add up and you say, look, there's digoxin, which has got a 1 on it, there's amitriptyline that's got a 3, and you'll end up finding that person has got a particularly high anticholinergic load, which means they're more likely to be confused, they're more likely to have falls, and driving is certainly out of the question once you get that load going up because of their confusion. So it's one of our big things to target. The ones that cause a postural drop, the prazosin I've mentioned, the fluid tablets I've mentioned, the antidepressants, the levodopa particularly, and most blood pressure tablets, particularly if they're fluid depleted. On top of that, not only do you have a fall, but you have a fracture. And that's even worse. The ones that are more inclined to make you have a fracture, the risk, again, those benzos, there's not a lot going for those, the oxazepam, the temazepam, and nitrazepam, and so on. Carbamazepine, corticosteroids, obviously decreasing bone mineral density, morphine, NSAIDs, phenytoin, proton pump inhibitors will decrease bone mineral density, as well the antidepressants, the selective serotonin reuptake inhibitors. So that's a problem as well. Here's Jean, she's 96, another oldie with lots of comorbidities again, and you can study these later for your interest at home, because you'll find patients that just about match this when you look at the patient profiles as you go through. So we can see we've taken a fairly detailed history so you can get the full picture about her. In the interest of time, I'm not going through it in great depth. But you can see here she's on paracetamol, she's on some vitamin D, that's probably okay. She was on Nexium, esomeprazole twice a day, it's gone down to once a day. She's still on that amitriptyline at night. That's increasing her risk. And she's your mum. That alters things. Okay. Diazepam at night as well. Does she have to get up to go to the loo at night with it? She's on a whole lot of Caloxil. Is she having her... You know my favourite thing for constipation? I told you I was a New Zealander. Kiwi fruit. Works extremely well. They're just coming back into season. What else works well? Pears. Pureed pears with the skin on. But it's basically fluid, and it's fruit and veggies, which a lot of these oldies don't have. So we try and increase that, and then we hopefully can decrease down their laxatives with it. As an aside, it brings to mind lactulose. Lactulose is not appropriate to be used every so often. Why? How long does it take to act? 24 to 36 hours. Shocking if you're using it in palliative care, because they're waiting, nothing happens. And if they're on a whole lot of high opioids, what do I see on the nursing home charts? I see lactulose given, yellow form, no result. Lactulose given, no result. Third day, lactulose given. Copious diarrhea, needs some Imodium. And somebody hasn't told them it takes a while to act, and it's an osmotic laxative. It requires a lot of water with it. And as for Movicol is fantastic, but it's expensive. And if you've got somebody on a fluid-restricted diet with heart failure, well then that's not really good, because they're going to be well over their 1.5 litres a day before you even start it. And you've also got quite a high electrolyte load. So Caloxyl with senna is probably my mainstay, but my kiwi fruit and my prunes and my pears are well above that. Okay. Papaya, yes. Actually, yes. Very good. So I think it's just thinking sensibly about what to do with that one. Where do we get there? Xylocum. How's she getting on? Hello, getting eye drops in her eye. Now, if she was in her own home, Buckley's. You know, so what's happening to a glaucoma, what's happening to a sight is getting worse. One drop only fits in the eye at a time. And when we have somebody that says 2 drops in, they put, or they might have 2 or 3 different eye drops, they go 1 drop, 1 drop, 1 drop, always the tissues, and they're all coming down the face. So when you put the eye drops in, 1 to 2 minutes between each drop and pushing on the nasolacrimal duct for, I say 2 minutes, and then they might hold it for 1 before they put the next drop in. Very, very handy to mention that to people, because otherwise that intraocular pressure goes up. Life-threatening, loss of sight-threatening, loss of blindness. So on some, and there she's on her lovely lactulose. If you're on lactulose regularly, it's okay, but you've got to make sure you have enough water with it. But then she's got some more PRM, so obviously she wasn't having a kiwi fruit or papaya. So she's got lots of problems with it. So here we have it, recapping, her amitriptyline and a diazepam, not good. The risk or benefit, so we need to try and get her off those as well. Why is she on the furosemide? Has she still got edema, puffy ankles or not? Look at her falls risk drugs. Timoptil at one stage was published in the Medical Journal of Australia of the single most common cause of hip fractures in elderly ladies because of the systemic absorption decreasing the blood pressure. So you're better off to use the more cardioselective ones as well, the betoxolol, but go to xylitane, you know, lantonoprost. You've got less postural drop with it as well. She can't swallow, so if you crush those esomeprazole, you won't get any effect of it at all. They've got to be dispersed in water and then swallowed. You can disperse esomeprazole, you can disperse omeprazole, you can't disperse pantoprazole, or the other one I can't think of at present, but you can get the granules of the somat granules, which they can disperse in water. So if they're still needing it, we need to find that they're not chewing them up, because otherwise it just gets wiped out by the gastric acid. If they can't swallow the vitamin D, we go to the tablets that you can crush, but you can go to the liquid if they can see to measure it. That's another thing as well, but that is debatable. The Caloxyl with senna, can that be crushed? It is bitter, but I don't have too many problems. So we've got to think about those crushing. Mentioned crushing before about the altered absorption, but they can be unstable, it can be irritant. If you crush some slow K, not that you can get slow K now because it's been discontinued due to the small traces of lead in it, but you can still get some of the other potassium ones, you'll get an irritant effect from it. Or you mightn't reach the site of action with the proton pumps. There's also a risk to you guys if you're administering medication as well of occupational health and safety. It should be no-touch policy. And unacceptable and indescribable taste. As an aside with that, I've had a lot of nursing staff that have been actually opening up antibiotic capsules and giving them to people. Now, if you're doing that constantly, you will be able to smell it and you'll end up endangering your own health due to resistance. And in most cases, there's a liquid that they can use. Okay, so be very careful if you see that happening with it. I've just written a paper on it from my homes as well. Okay, here's Marjorie. She's getting older. Oh my goodness, I told you I was doing the old person. 110. And there she is at that nursing home that you saw at the start with a lovely girl who, the director of nursing who has MS, who's still was managing to hold down a full-time job, but she had a bed that she could go and lie down every so often. So that is a picture which I had permission of. Marjorie is now passed on, but 110. Now, I mean, you just think, hey, is this real? What am I talking about? She had the same doctor for all the time, losing weight. She had a few allergies. She was getting frail, but she doesn't look too bad, does she? You know, she's got arthritis. She's basically a bit loss of sight, atrial fibrillation, hypertension, type 2 diabetes. She's still got all these conditions, and she's 110. Wow, opening your eyes, isn't it? She had been in that home for 16 years. It was very nice, you know. Really amazing, isn't it? Yeah. Supportive family, cognition was minimal, some verbal cues. She was still having amitriptyline at night. She was basically continent, which was pretty incredible with it. There they are doing their knitting group there, keeping them busy as well with it. She gets round. So, you know, she's managing pretty well. So these are her medications. And you say, hey, get rid of those. But do you? She's got to 110. So this now becomes an ethical dilemma because she's happy. So maybe in this case, even though I don't like it, we stay. I don't know. So she's got a bit of Voltaren gel. She's got a little bit of amitriptyline. She's got dry eyes. Metoprolol, a quarter daily, keeping that heart rate down a bit slower because she had atrial fibrillation. She's got glucosamine, which I'm going to tell you has got minimal evidence. She's got a little bit of furosemide. She's got a little bit of a whiff of digoxin. She's got some eye drops. She's got a patch. She's got the paracetamol. None of the following that were put up by the GP had been used. And she had no palliative orders in place. So isn't it amazing? I thought she was a very interesting case to share it with you as well. There's a pathology for those that wish to look at it. And we can look at it through her various things that I've analysed. So we can have issues for discussion with these older people. 103 men, sexually inappropriate behaviours. So we had to put him on cyprosterone. Residronate, and 101 lady with dementia, just admitted from the community. So she's still on it. So here am I saying deprescribing, but I've got some that we've got to keep on it. So we need to think about under or over treatment as well. Oxybutynin, get classified as incontinent. That one's got to go. We look at all the asthma, the COP devices, and make sure that they can use them. And that's one of my favourite lectures that I did last year, so they didn't want me to do it this year. So what I would like you to all think about is making sure that in your surgeries that you have got some aids in front of you that you can get from the National Asthma Council. You can get a poster. I didn't bring the A3 one along. These are all freely available. All you've got to go onto the National Asthma Council website and request this information. That gives you all the various devices, including all the new ones, classified. When I give that to the GPs, they go, oh, that's really good, thank you, I can sort it out. And with that, hand in hand, comes a little handout sheet that you can get off the NPS website of how to use them all, the instructions. Or you can look at the videos there. There's videos of every device on the National Asthma Council website, on the Asthma Australia website, and on the Australian Lung Foundation website. So you've got them all. You've also got on the Australian Lung Foundation website all the medications used for COPD and the plan, a double-sided piece. This is meant for GPs and for GP practices. Okay? We've got guidelines that are 50 pages long. They don't read them. So we've got to keep it simple. We've got all the conditions for allergic rhinitis, which was another heavy horse of mine, and we've got the COPD assessment risk. And one of the people here Mary was telling me about the work that they'd done in education of people with COPD. You guys and us have got a lot of work to do with asthma and COPD. We're also moving towards a lot of pharmacists working in GP practices. This is something that they love, and it's a task that you can give them to start them off, to get them going if you are lucky enough to have somebody, because it's another pair of hands to do a lot of the stuff that you're having to do. Okay, so yeah, I only need that to start me off on triggering on that one. I've told you about the eye drops. PRN use of antifungals is one of my big no-nos, because that when we looked at the antimicrobial stewardship survey in aged care again, number one is cephalexin, number two are the antifungal creams, and they just use PRN. We get huge resistance. If somebody needs to have some canistin or some dactarin, they need to have it regularly twice a day until the rash is gone, and then a further 2 weeks after. Otherwise, that fungi says, I love dark, warm, moist places, and particularly with a feed of glucose, if they've got some diabetes, and I'm back again. And they keep coming back, and it can be really quite distressing. So that is one of my big things. Ongoing use of PPIs, and I'll talk about that just before lunch. Hippuric acid, that one has really gone out. It's just useless. It has very little evidence for it as well. Our big thing at present is all the audits of people using antipsychotics for what is called chemical restraint in the aged care homes. These people are very distressed. We're often using them more than we should, but in many cases, all else has failed. So that's another debate about it. Or oxazepam. Oxazepam was the one that people were going to, but unfortunately, if you get the residential aged care communique, there's a case written up that I unfortunately had a bit to do with, of a poor lady who actually had over 2 months a person with dementia. It involved 2 homes, 2 visits to an acute hospital. She was put on a number of medications for depression, but she had Alzheimer's disease, and the GP first prescribed oxazepam, 7.5 to 15 milligram twice daily. That was escalated up to 15 milligrams 3 times a day. She was hospitalised. She had unwitnessed falls. She went into one hospital. She went to one nursing home. She went into another hospital again. She went into a nursing home that I actually had the contract of. And this was in January. I got a message in New Zealand that we'd had a death there. It was being investigated. I actually hadn't seen this lady because she'd only been there for a week. My favourite GP there had gone in, assessed her, and given the same dose as what it had before, oxazepam 8, 12 and 5 p.m. and as necessary. So that meant she was having 45 milligrams of oxazepam a day. She had 7 falls with multiple head strikes over the next few days, and unfortunately the nursing home staff did not promptly notify the doctors or the family of this falls. She died about 4 days later in hospital as a result from pneumonia caused by fractured ribs from the falls. So oxazepam, people are watching out for. It causes falls, So it's pretty nasty. That GP is devastated. She's not working again in aged care. She did what the previous doctor had done without thinking, and the nursing staff didn't relay the number of falls that she'd had. So terrible, oxazepam. So what do we think of? Blood pressure, how low do we go? Statins, what are our targets at? And atrial fibrillation, do we use an anticoagulant? In which case, if they have a fall and they have a head strike, they've got big problems and they've got to go to hospital. As an aside, if they're on warfarin, they're more likely to have a cardiovascular or cerebral vascular bleed. If they're on the new NOACs, they're more likely to have a GI bleed. So maybe you might prefer to go on those ones. Diabetes, what are the targets? How low do we go with it? The renal function, what's going on? The kidneys don't go too well as you get down, and you've got to reduce some doses. Analgesia, under or over treatment. We've spoken about melatonin, and we've spoken about when do we deprescribe. I've given you a chart here for medicines that you don't suddenly stop. So you don't suddenly stop low-dose codeine. The people that were getting it over the counter before it was up-scheduled, they would suffer withdrawal and they would do everything to try and get it. You don't suddenly stop antidepressants, benzos. You certainly don't suddenly stop beta blockers. They've got to be weaned off very slowly over 2 weeks. Otherwise, they will end up having a rebound, blood pressure going up, and a rebound tachycardia. So we're using a lot more of them now for rate control. So watch that very carefully. Clonidine, you don't stop suddenly. Corticosteroids, you only need slow weaning if they've been on them for a long time. So if you've had somebody that's had a flare of their asthma or their COPD and they're on them for 3 or 4 days, no problem. Because they can have 50 milligram or 25 milligrams for 3 days and stop. But somebody who's been on them long-term, higher doses, need to go down very slowly. Otherwise, they really feel terrible. When they're put on a high dose of a corticosteroid, everything is suddenly rosy again. Everything was black. They had really bad asthma flare, bronchiectasis, whatever it might be, and you give them the prednisolone, and they take that, oh, it's lovely, I'm better now, I'm fine. You suddenly stop those. For that severe person, they go, oh, everything looks black again. So there were some cases where we would wean, but it's not routinely done. Levodopa, you don't suddenly wean. Proton pumps, if you stop them suddenly, the tummy says, hello, I need the proton pump, I better create some more acid to get it, and so you get a rebound hyperacidity. And they say, I can't do without it. We'll talk more about that if we have time before lunch. Let's go. So, in the summary, in the older person, and here's Laurie, and Laurie's best friend is the cat. Okay, that's Tui there, who's sitting there, and he spends most of his days in his chair, but he's under home care. So he has somebody coming every 3 times a week with that particular gentleman. Non-drug for constipation. I haven't told you about non-drug for sleeping. Do we use sleeping tablets? No. Often, in the nursing home situation, I use rolled oats. Yeah, rolled oats. Why? Because they've had their main meal at lunchtime. They've had a soup, sausage roll, and some jelly at 5 o'clock at night. They go to bed at 7 o'clock. At 11 o'clock, 12 o'clock, they're lying in bed, they can't sleep. They're hungry. So give them some rolled oats. It works well in their own situation too. They can get up and get their rolled oats, or they can get a sandwich with a milky drink. So think about what time they're eating, whether that's been causing their insomnia. Is it other problems that are going on? Is it pain? All these other things as well. But don't just say, oh, you need a sleeping tablet. Pain is possible. Again, I've mentioned the physio, the massage, the weight loss, and behaviour problems are diversional. So our targets are, and this is a lot of yours with your health assessments, weight reduction, good nutrition, alcohol limitation, no more than 2 drinks per day and 2 alcohol-free days per year. No, per week. per week, yeah, okay. So preferably no alcohol is the current thing, but you've got to look at each case and see what is possible for that person to achieve. Appropriate exercise, and the exercise clubs are just booming. Smoking cessation, oh yeah, that's a hard one. Does anyone watch Hard Quiz? I can just see Tom Gleeson saying to somebody, right, stop smoking, out, come back when you have. And that's what some of the cardiologists do, and some of the respiratory specialists. They are so hard. And it's left to you guys. Who's a quit counsellor? Yeah, how hard is it? You guys deserve gold medals. You know, so few pharmacists do quit counselling, but it's something you could consider because it really is a motivational type thing. So good luck with it. Activities and socialisation. What clubs are on? What can they go to? If you've got somebody in your care who comes in and they're really distressed, and they're distressed because they're looking after somebody with dementia, which is an increasing problem, have we got a daycare centre where that person can be got the council bus and go off for a day to give your carer a day off? Because otherwise your carer is going to come in wanting an appointment because they're depressed, because they can't cope. So you've got to think about big, broad things outside the square. Presenting symptoms may be ADRs, well, that's a subject unto itself. Minimum medications we can. Is preventive medicine rational at this point in time? Can we rationalise it? Keep it down simple. And how is their quality of life going? What about their drug allergies? And the red flag drugs, the things that really cause problems. Amiodarone, when did they last have their blood test done? Okay, clozapine, blood test. Digoxin, blood tests. Pulses. Lithium, blood tests. Methotrexate, blood tests. Yep, I might. Vancomycin and warfarin, etc. And watch out for those anticholinergics, the NSAIDs and the psychotropics. Anticipate side effects. Start low and then gradually go up. Be prepared to make appointments for them coming back. You nurses are going to have a much bigger role. You know, in New Zealand, you've got nurses prescribing. Here, I think you're going to be prescribing, some of you, before too long, as well as our nurse practitioners as well. Anticipate difficulties in swallowing. Risk versus benefit. Bloods when necessary. Recalls, absolutely vital. Your recalls for your polio at 6 months. Your recalls for your vaccinations, etc. coming now. And your cost of your medications. So, it's morning tea.